You remember that the first time that we use a lower trapezius transfer is for paralytic shoulder, and in the same period, Jaime Bertelli in Brazil and Bassem described this technique with an allograft, with a very nice result. On the first point, if you do tendon transfer, the most important is the passive range of motion. If the shoulder is stiff, the tendon transfer doesn't work. This is the first point. Is the reason why for paralytic shoulder, the result is very nice if you do tendon transfer for external rotation. The second publication was in academy. It was a poster did by Galatz, Lisa, on the 14 cases. It was massive posterior superior curve tear. It was a rupture of the supraspinatus and infraspinatus, and in 80%, the teres minor was working. And you see that she did the electric myographic study, and they found a co-contraction. When you do external rotation, you have a co-contraction of the lower trapezius. Is one of the reasons what this is the best transfer for external rotation. And she analyzed with ultrasonography control, and it's very useful. You can see the mobilization of the graft when you do external rotation after the operation. Is a better control, is better than MRI or X-rays. You can do ultrasonography to follow your extending graft between the lower trapezius and the humeral head. So Bassem described a big series of open technique. Teres minor was functionalized in 70%, and he obtained very nice result regarding the function, external rotation, and elevation. On the conclusion that he tried to push the indication for patients with less than 60 degrees of forward elevation, but this tendon transfer is not enough to restore forward elevation if you have an elevation before less than 60 degrees. So, come back to the anatomy and to the laboratory, because the insertion of the lower trapezius on the dorsal and lumbar spine. On the distal part is the medial angle to the scapula. There is a very good tendon. Regarding the innervation, it's very important to remember that this is a spinal nerve. And now, when you do tendon transfer, you use during the operation an electrostimulation. It's very safe. You ask to the anesthesiologist to have a needle with a stimulator, electric stimulator, and you look for the nerve before to do a large dissection. And I think that is safe technique with this system. It's 2 centimeters medial to the medial part of the scapula. This is the direction of the nerve in the deep part. And more important, there is a co-contraction of the lower trapezius when you do external rotation. But of course, if you want to reach the humeral head is too short, and you have to extend with a graft. So back to the paper of Guillaume Herzberg from Lyon, and he compares the excursion and the strength of many tendons. You see that if you want to restore infraspinatus, the best is not the lower, the latissimus dorsi, because the excursion is completely different, but the lower trapezius is close to the infraspinatus. Teres minor is not so bad, you see, regarding the excursion, but the strength is not enough. So this is a very nice paper, Robert Hassler in Mayo Clinic, regarding the function of the tendon transfer when you have the arm close to the chest. The best for external rotation is lower trapezius. When you have the arm in abduction and to have external rotation, the best is the latissimus dorsi or the teres major. And I follow this biomechanical study in my indication. So this is the same vector, is agonist. This is very nice. Excursion is close to the infraspinatus, but less strength. So the indication for us is a dropping sign or Hornblower sign, no active external rotation, and after 6 months of physiotherapy. And there is sometimes a weakness in external rotation. But pseudoparalytic shoulder is for us a contraindication of lower trapezius transfer. So regarding the imaging, I selected the patient with atrophy of the teres minor in 100%, rupture of the infraspinatus, and rupture of the supraspinatus. And the subscapularis was good, or partially lesion of the superior part, and I repair the subscapularis. So this is, for example, an excellent indication for us. There is no active external rotation. Sometimes the patient is able to have a good elevation, you see that, but a humbleness sign. This is a good indication of a lower trapezius transfer. This patient is very interesting because in abduction, you see that there is an external rotation, and you have no teres minor, no infraspinatus, and no supraspinatus, but you have a big posterior deltoid. And when you do examination of the shoulder, you have to examine the posterior deltoid. And during the physiotherapy, you have to increase the strength of the posterior deltoid because you move better the hand in elevation. But you see that there is no external rotation in zero abduction, and this is a very nice indication of lower trapezius transfer. So when you do operation, every time you try to repair, because if you repair partially, it's better. If you repair partially the infraspinatus, but in this case it was not possible, you have to repair the subscapularis. This is a complete contraindication for us of the tendon transfer on lower trapezius. This is a pseudo-paralytic shoulder. The definition is a superior and anterior migration of the humeral head with active elevation less than 60 degrees. And you see the joint is completely destroyed. But you have to test the deltoid, because if you have a weak deltoid, the tendon transfer doesn't work very well, because deltoid is a very good friend of the tendon transfer. And you have to test the deltoid and to do hypertrophy of the deltoid if you want to do a tendon transfer. In this case, a reverse prosthesis work well. And sometimes if there is no external rotation, you can do latissimus dorsi, episcopo, or lower trapezius. Regarding the technique, I use the same technique of Bassem with a small incision to detach the tendon on the lower trapezius. And I extend to reach the humeral head with a semitendinosus graft, because I use a allograft, but I had an infection with the allograft, and now I use a semitendinous tendon. I do 4 portals because I fix by arthroscopy, and I do a small incision to detach the lower trapezius. Regarding the harvesting of the semitendinous is classical. You see, I do a small incision at the level of the knee, and I detach 20 centimeters or 25 because I use a dual graft, because the size is 5 millimeters, but is enough to obtain a good resistance and a strong tendon graft. So the key point during the surgery is to locate the spinal accessory nerve, to use a graft of 25 centimeters because we have a dual tendinous graft. We fix first at the infraspinatus level on the great tuberosities with 2 anchors, and I have 2 positions of fixation, one anteriorly, one posteriorly, to have a contact with the great tuberosities. And the tension should be maximum. And for me, the most important now is immobilization. And I use a cast during 6 weeks. It's not comfortable for the patient, but I am sure that the patient stay in abduction and external rotation. I explained very well during the consultation that the cast should be kept during 6 weeks, and I increase my results. So at the beginning, I use allograft. After, I use a fascia of the infraspinatus, but the incision is bigger. And now I use a semitendinous. So I published my 15 patients, first patients between 2013 and 16. The mean age is 62, follow-up 30. Indication was absence of teres minor, rupture of the supraspinatus, rupture of the infraspinatus. I tried to combine lower trapezius and latissimus dorsi, but it was not useful. I don't know why, but I tried to push the indication for patient with elevation 80 degrees, but I have no result. It's very interesting to know that we correct in 100% the dropping sign on the humbleness side. The external rotation that you can expect is the mean 24 degrees. It's not a lot. I think that I can increase this result if you stabilize in the cast. But you see that the gain is 44 degrees. And external rotation is better, and you see that the function of the shoulder is 70. It's not so bad after tendon transfer. So this is an example. You see atrophy, complete atrophy, young patient, very active. And I did a lower trapezius transfer. This is typical the result that I obtained. It's not a lot for external rotation, but for the patient it's very important because he increases many movement during daily activity if he has 20 degrees of external rotation. Another patient here with the same result. So there is no significant difference between the three grafts. We have two hematoma, and I recommend to wash the incision on the back, and the limitation is small series. So the first conclusion is if you want to restore active external rotation, you have a good, and you have no teres minor, you have a good subscapularis. I think this is an effective procedure to restore active external rotation. And I select the indication of atrophy of teres minor. When I have a rupture of the supra and infraspinatus, I prefer to do latissimus dorsi transfer. And I try to repair partially. It's very important to repair the subscapularis. So I propose you this algorithm, but this is for the discussion. If you have no active external rotation, but a limited active forward elevation, you can do lower trapezius, or you can combine lower trapezius and latissimus dorsi for the elevation. If you have a complete elevation and no active external rotation, position 1 and 2, this is a very good result of lower trapezius. I use episcopo described by Pascal, but the result is less for me, and I prefer to do lower trapezius. If you have no external rotation, no active forward elevation, you have to combine tendon transfer with reverse arthroplasty. Thank you very much.